Good morning, everyone. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The title of my lecture today is Preterm Labor. So, what we wanted to know about preterm labor? The definitions, the incidence, risk factors, etiology, prediction of preterm labor, diagnosis, how to manage, and lastly, the complications. The definition of preterm labor is regular uterine contraction with cervical changes leads to dilatation and the effacement of the cervix when gestational age is less than 37 weeks. So, from 20 to 37 weeks is considered preterm labor. What about preterm birth? Is the delivery of the baby before 37 weeks gestational age. And you can classify them into three categories. Either very early preterm from before 32 gestational age, early preterm from 32 up to 34 or less than 34, and late preterm starting from 34 and ending before 37. Okay, so very early preterm, and late preterm. This is three category of preterm birth. 9.6% of neonates are born preterm before 37 weeks. 2.7 born before 34 weeks. 50 of these births were preceded by preterm labor. So it is considered a major problem in obstetrics, and of course carry a morbidity and mortality as regard the fetus and infant and later on in life. What are the risk factors? Low socioeconomic conditions, poor nutrition, less education, low income, maternal characteristics like maternal age before the age of 15 or between 45 or 49, so early marriage and pregnancy or late marriage carry a risk of preterm labor. Smoking during pregnancy, either active or ex-smoker or passive smoker, body mass index less than 18, occupation which needs more physical effort may cause preterm labor. Coitus during pregnancy, especially if it is frequent. Obstetric factors like multi-fetal pregnancy, previous delivery of preterm baby, previous spontaneous or induced abortions, previous preterm delivery, and previous delivery of baby of underweight. What is the etiology? The etiology may be chorioamnionitis or other infections like urinary tract infection, vaginitis, cervicitis, especially bacterial vaginosis. Maybe placental abnormalities like approach placentia or placenta previa. Maybe congenital anomaly in the uterus, incompetent cervix, or bicornate or unicornate uterus or septate uterus. Fetal anomalies like neural tube defect, over-distended uterus due to polyhydramnios or multi-fetal pregnancy, preterm rupture of membrane, intrauterine fetal death, elective induction of labor yearly, past history of previous preterm labor, serious maternal disease, cardiac disease, or others. Also, antiphospholipid syndrome is very important, malnutrition, and any current stressor, whatever emotional or mental, and overwork and excess effort, or it may be idiopathic. Reduction of preterm labor. We have identification of patients at risk for preterm labor, the daily habits, socioeconomic factors, previous medical history, and the aspects of current pregnancy. All of them are used to predict preterm labor. It's very important to detect early warning symptoms and signs of preterm labor. So, what are the early symptoms for prediction of preterm labor? Menstrual-like cramps, dull aching pain at the back, abdominal cramping, vaginal discharge, fluid leaking from the vagina, uterine contractions that are 10 minutes apart or closer or less. So, what is the evaluation of uterine activity and cervical changes? Clinical, by monitoring uterine activity by special devices and by doing pelvic examination to assess cervical ripening and effacement. As you see in this picture, this is the cervix, which is well formed, 0% effaced, so no effacement here, and here nearly 100 effaced and ripe cervix. So this is a warning sign during PV examination, the cervical ripening and effacement, also monitoring uterine activity by special devices. Okay, what else? Transvaginal ultrasound. Yes, look to this picture, please. We can do cervicometry by measuring the cervical length. As you see here, the cervix becomes short. It is less than 2.5 centimeter here, while the normal should 3 or more centimeter. Also, dilatation of the internal os and the funneling of the internal os here, of the upper part of the cervical canal, there is funneling, and the bulging of the membrane. All these are warning signs detected by transvaginal ultrasound. Also, thinning of the lower uterine segment is a sign also of preterm labor. So if the cervix is less than 3 centimeter, or somebody say 2.5 centimeter, or widening of the internal os, this is the internal os, widening of the internal os 6 millimeter or more, or thinning of the lower uterine segment, or bulging of the membrane through the funneled pelvis, all these are warning signs by TVS. Okay, what is the lab finding? Yes, one of the important lab findings is fetal fibronectin in cervical and vaginal secretions. Please look to this picture. We are doing speculum examination using sterile speculum, of course, under complete aseptic condition. We insert the probe inside to take a swab, then insert inside the buffer in this bottle, then remove the probe and shake the bottle. Okay, then do this test for fibronectin as you see here. So these are the steps to detect fibronectin. Actually, fibronectin is a good negative. I mean, its specificity is high while its sensitivity is less. So it is good negative. Okay, so if it is negative, yes, the possibility of occurrence of preterm labor within 1 week is low, especially if the cervix is 3 centimeters by TVS. Okay, okay. What other lab finding? Mediators of inflammation and infection like interleukin 1 and 6, tumor necrosis factor in the cervicovaginal secretion. Also, you can do a rectovaginal group B streptococcal culture. So take swab and do culture for group B streptococcal infection because it is important and it's considered also risk factor. Biochemical markers, sensitive markers when increased predict preterm labor like saliva estriol to progesterone ratio, serum collagenase, serum cervicovaginal protease, corticotropin releasing hormone. All these are considered biochemical marker which is sensitive marker for prediction of preterm labor. Also we can do lab investigation like CBC. Of course, in infection there is leukocytosis, urine culture and sensitivity test for urinary tract infection, and the blood glucose to detect if there is any diabetes. What is the likelihood that the patient will deliver prematurely? Negative fetal fibronectin test result, as we said before, and the cervical length of at least 3 cm on ultrasonography, we have low likelihood of delivery within 14 days. Okay? So combination of both negative fetal fibronectin together with cervical length 3 cm by transvaginal ultrasonography have a low likelihood of delivery within 14 days. As you see in this picture, this is normal cervical length, which is considered 3.2 centimeter, and the internal os here is closed. Okay, let us go on to the diagnosis of preterm labor. Okay, we can divide into two main groups: assessment of uterine contractions and cervical changes and premature rupture of membrane. This is one group, and another group, diagnosis of preterm infant, either before delivery or after delivery. Okay, assessment of uterine contraction by measuring the uterine contraction, the frequency of the uterine contraction, and it can be tested by certain devices like CTG, and also its effect on the cervix as regards the dilatation and the effacement can be measured. Okay, also you should test for PROM, premature preterm rupture of membrane. Is it present or not? Okay, okay. While diagnosis of preterm infant before delivery by using clinical data from history, examination, and ultrasound, measuring the biparietal femur length and so on to detect gestational age, and from the last menstrual period you detect the gestational age also. Also other items in ultrasound like placental site, any abnormality, placenta previa, abruptio placentae, any multifetal pregnancy, any polyhydramnios, all of these could be detected by ultrasound. So I'll detect the gestational age from history and from biometry, fetal biometry by ultrasound. Also there is lab investigation, which is very important also. Let us see in details. Okay, assessment of uterine activity and the changes in cervical effacement and dilatation. Preterm labor is diagnosed when patient is having regular uterine contractions that are accompanied by progressive dilatation and cervical effacement. Actually, accuracy of clinical diagnosis is increased when there are at least 6 contractions per hour. Cervical dilatation is more than 3 centimeters. Effacement is at least 80%. Membrane are ruptured or there is vaginal bleeding. So these items only to increase the accuracy of clinical diagnosis. But efficient uterine contractions that cause cervical effacement and starting dilatation is sufficient to diagnose preterm labor. Okay? Okay. As you see in this picture, this is the effacement. This is cervix not effaced. This is 30%. This is 100% effacement. And this is the uterine contraction through device. Okay. Are the membrane ruptured? We should ask ourselves this question. Is there any history of leaking fluid? Observed leakage or pooling of fluid from cervical os on sterile speculum examination. While you insert this is the casco speculum examination. This is the casco speculum. We insert it, should be sterile, and we will see leakage of fluid through the external os. And we'll take a sample from this fluid and do test. Positive nitrazine test means it is amniotic fluid because it is alkaline, so it will give the blue color. Also, we'll do another test, arborization or ferning of this fluid under microscopic examination. Also, positive amniotic protein test result like placental alpha microglobulin 1. So this is to confirm the presence of rupture of membrane. Okay. Diagnosis of preterm infant. The other category, as I said before delivery and after delivery. Before delivery, clinical data is very important to detect the gestational age from last menstrual period, which will be accurate if reliable. What is meant by reliable? That the last menstruation was normal character. The last menstruation was preceded by 3 normal menstrual cycles. The previous 3 cycles was free of any hormonal drugs as contraceptive pills. So, if this criteria fulfilled, so the date will be the last menstruation is reliable and the date will be certain. Quickening also can be used to detect the gestational age. Also, clinical evidence of gestational age by the size of the uterus, the fundal height, measuring of symphysis fundal height by tab measure, also by the ulnar border of the hand, we can detect the fundal level during doing the grafts. Also by palpation of the fetal parts and tone. So we wanna to know the gestational age and to confirm the clinical data. Okay. Laboratory data like amniotic fluid studies for bilirubin, creatinine, LS ratio, detect lung maturity, which will be mature if it is 3:1 ratio, and the fat cells. Radiological data by ultrasound, by fetal biometry, by parietal diameter, femur length, abdominal circumference. Also, you should know the site of the placenta, any abnormality of the placenta, abruptio placentae or placenta previa, the amniotic fluid index, and viability of the fetus. Everything about obstetric ultrasound should be fulfilled. So the ultrasound will confirm also the gestational age. Okay, so from history and the clinical, the gestational age was detected, and the ultrasound will confirm it and will give me another benefits also, as we said. X-ray was used in the past when ultrasound wasn't available, but nowadays it is of no use for this, for detecting the gestational age of the baby. Okay, at 36 weeks by X-ray ossific center in the distal femoral epiphysis. At 38 weeks, ossific center in the proximal tibial epiphysis. At 40 weeks, ossific center in the combined bones. Okay? What about after delivery? After delivery, I'll see signs and the feature of birth indicating prematurity. Like what? Like body weight less than 2.5 kilogram and the crown heel length less than 51 centimeter. Like abdominal circumference less than 35 centimeter. Fontanelle wider and the scalp hair fine. Head size relative to body is greater than at term. What about the skin of the baby? It is bright red in color, thin, wrinkles, easily, lanugo hair plentiful, while the vernix caseosa scanty or absent, ears soft and flabby with less cartilage. If the baby is boy, testicle undescended. If the baby is girl, clitoris prominent and the labia majora small and widely separated. Sole crease, anterior crease only at 36 weeks. Okay, as you see in this picture, this is the lanugo hairs. Okay, absent also vernix caseosa and wrinkled skin, and you can see also in this other picture, this is a preterm baby. Okay, the other item which is important is the neurological reflexes. As you see in the picture, like suckling reflex, as you see here, when you put a finger inside the mouth, the baby will suck. Grasp reflex, when you put finger in the palm of the hand, the baby will grasp it. Another reflex is like Moore reflex and deflection angles. So, and the muscle tone. So, all these neurological reflexes also indicating preterm labor. Management of patient at high risk for preterm labor. It is very important to educate the woman about preterm labor. Treatment of cervical, vaginal, and urinary tract infection is very important. Cervical assessment, either clinical or by ultrasound. Cervical cerclage when needed, if there is short cervix or incompetent cervix, or there is history of previous mid-trimester abortion or history of previous preterm labor, by doing cervical cerclage. Serial ultrasound examination to evaluate the cervix and evaluate the fetal well-being. Coital abstinence, limitation of physical activity, change in working conditions, less effort, less physical effort if the patient is at high risk. Progesterone supplementation can start at 16 to 24 weeks gestation and continue through 34 weeks gestation. Adequate nutrition and hydration and rest and avoid smoking. All these are important items to manage patient at high risk for preterm labor. As you see here, this picture show you the cerclage, McDonald cerclage here, which is done at the gestation age 12 to 14 weeks. Okay, cervical cerclage, I have two different types in different times. Either I'll do cerclage at the gestation age 12 to 14 weeks, which is called McDonald cerclage or Cervical cerclage. Of course, this is done if the fetal well-being is very well and I have incompetent cervix, I have history of mid-trimester abortion or preterm labor, or if I did by transvaginal ultrasound cervicometry and I found short cervix less than 25 millimeter or internal os dilated more than 1 centimeter. So I should do it as a prophylactic measure for prevention of preterm labor. Another type of cerclage is a rescue treatment cerclage or emergency cerclage. This is done when cervical change is already detected. So I have an incompetent cervix and threatened preterm labor, and there is cervical changes, so I can do it as an emergency cerclage at any time. Okay? So, what is the management of women with warning signs of preterm labor? Bed rest in the lateral position, adequate nutrition and hydration, antibiotic for infection, bacterial vaginosis, urinary tract infection, cervicitis, prophylactic tocolysis, administration of steroids to enhance fetal lung maturity, search for the presence of placental insufficiency or other abnormalities. Preterm labor shouldn't be interrupted in the following cases. So you shouldn't interfere if there is preterm labor in the following conditions. Severe maternal diseases like severe preeclampsia and severe cardiac disease. Advanced labor, there is nothing to do. Lethal fetal congenital anomalies. Fetal growth restriction. Fetal chromosomal abnormalities. Chorioamnionitis. Adequate fetal lung maturity. So you are not to do anything or interrupt the preterm labor. What about the guidelines for tocolytic drugs? To start between 22 up to 34 weeks of gestational age if there is no contraindications. This is very important to be mentioned. The classes of these drugs include calcium channel blocker like nifedipine, which is preferred because of fewer side effects. Has side effects like headache. What else? Beta adrenergic. Most commonly used beta 2 agonist is terbutaline. So terbutaline is the commonest to be used in this group of beta adrenergic drugs. Of course, it can cause side effects like tachycardia. In the past, there were another drugs like ritodrine, beta-mimetic drugs, but due to side effects like pulmonary edema, arrhythmia, and so, it is nowadays it is not of use. Okay, so beta-mimetic or beta-adrenergic, which is in use, is terbutaline with less side effect than ritodrine. Cyclooxygenase inhibitor, COX inhibitor, like indomethacin, is safest if given no longer than recommended 48 hours. Why? Because there is risk of premature closure of ductus arteriosus. So be careful about this, not to give indomethacin more than 48 hours because I have a risk of premature closure of ductus arteriosus. Nitric oxide donors, another tocolytic drug, safe drug. Atosiban, which is oxytocin receptor antagonist, another safe drug. Magnesium sulfate, you should know that mother on this medication should have monitoring for the following: respiratory rate, vital signs, magnesium level in the blood, deep tendon reflex, urine output, and any respiratory depression. And you should stop it if any toxicity happened with magnesium sulfate. Okay, so the patient should be monitored very well. Glyceryl trinitrate, another drug. Progesterone supplementation is controversial to be given in an already case in preterm labor. Yes, we mentioned before we can give it in high-risk cases as a prophylactic measure starting early in mid-trimester. We said that as a prophylactic in high-risk case, but in active preterm labor, there is controversy about its effect or benefit in such situation. It's very important to know that no maintenance tocolytics that prevent preterm birth and prevent morbidity or mortality for the fetus. So the aim of tocolytic drug is just to give a chance for corticosteroid to enhance lung maturity, which takes 48 hours at least. So if you can continue more, it's okay. But this is the main target, is to give a chance for corticosteroid, which is given to the woman to enhance fetal lung maturity, to complete its action. Another target for giving tocolysis is to give a chance also to transfer the patient to a well-equipped hospital with ICU and incubators available and senior pediatrician consultant specialized in neonatologist and well-equipped hospital. So this is the two aim of giving tocolysis, the main target for giving any of the previously mentioned tocolytic drugs. Okay, antenatal administration of steroid to enhance fetal lung maturity. Patient who will have maximal benefits, those before 34 weeks, as we mentioned before, those with immature fetal lung, those who will deliver in more than 48 hours to complete its action. What about the dose? Accordingly, I'll give betamethasone or dexamethasone. If I'll give betamethasone, I'll give the patient 12 milligram per dose, given in 2 doses 24 hours apart. If I'll give dexamethasone, I'll give the patient 4 doses of dexamethasone, 6 milligram intramuscular, 12 hours apart. Both of them given intramuscular. Administration of magnesium sulfate in preterm labor before 32 weeks for neuroprotection is very important. So don't forget to give the patient magnesium sulfate if the gestational age is before 32 weeks, because it is proved that magnesium sulfate has a neuroprotection for the fetus. Administering appropriate antibiotic in labor, especially if there is BROM, to prevent group B streptococcal infection. This is the picture of dexamethasone ampoule, how it looks. This is magnesium sulfate 10 milliliter ampoule. Woman presents to the hospital at more than 34 weeks. What you are going to do with her? So you will examine her clinically, take history, do clinical examination, and do ultrasound. And if you found everything is fine and there is no progressive cervical dilatation, and you kept her for 6 hours under observation, and no more effacement or dilatation of the cervix, at the same time there is reactive non-stress test, and there is no complication in the pregnancy, so you can, after 6 hours, let her go home and ask her to come again for follow-up after 1 to 2 weeks. And she can return at any time if any additional symptoms or signs occurs. Okay? Or any other pregnancy concerns. So this is an example for how to deal with a patient or woman coming to you with symptoms and signs suggesting preterm labor, and she is more than 34 weeks gestational age. Okay? What about the conduct of preterm labor? The patient should be kept in bed throughout labor because precipitate labor is often expected. So, keep the patient in bed. It is important. Also, to avoid preterm rupture of membrane. Preterm labor should be conducted in a center where facilities for intensive neonatal care are available. Minimal use of oxytocin and analgesia with close monitoring. Epidural block is good unless the maternal condition prevents its use, like hemorrhage, antepartum hemorrhage, severe preeclamptic toxemia, so bleeding tendency. So this is contraindication for epidural. But if there is no contraindication, epidural block is good. Pudendal block and perineal infiltration are excellent for delivery. Episiotomy, like this in this picture, once head reach the perineum is very important. Why? Because I wanted to avoid compression, decompression on the head. Because this preterm or premature baby liable for intracranial hemorrhage. So I wanted to avoid the compression, decompression, the sudden compression and decompression. So I'll do episiotomy. Also, I'll deliver the head gently to avoid intracranial hemorrhage also. Cesarean section is the safest for premature fetus, particularly when the presentation is breech. Delayed cord clamping is suggested to be has many advantages. It increases the hematocrit, increase hemoglobin concentration, decrease the occurrence or the time for resuscitation for this baby. So many studies suggest delayed cord clamping to give more care for the baby because it has many advantages, as I said. What are the complications on the fetus? There is, and the infant, and the later on in life, I have short-term effects and the long-term effects. Short-term effects like respiratory distress syndrome, which is very important, intracranial hemorrhage, diminished resistance to infection, disturbance in heat regulation, anemia, kidney immaturity, malnutrition, jaundice due to inability of the liver to conjugate bilirubin due to enzymatic immaturity, necrotizing enterocolitis. This is the short-term complication. What about the long-term effects? Higher incidence of neurological, behavioral, and intellectual abnormalities, autism, cerebral palsy, delayed in gross and motor disabilities, and so on, mental and behavioral and neurological complications. This is the last slide. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.